Hi there, it's my pleasure to speak to you today about cannabidiol or CBD and this continued question as to whether it's all hype or whether it is in fact a clear treatment for drug-resistant epilepsy. I'm Blathnaid McCoy and I'm a practicing paediatric neurologist and epileptologist. So my proposal is to speak briefly about what is drug-resistant or refractory epilepsy. What are the current therapies that we have and what role does medical cannabis and indeed CBD have in all of this? When we talk about epilepsy, there's a couple of terms we need to be clear about. A seizure is that paroxysmal, either motor, sensory or autonomic event that occurs because of an abnormal, excessive and synchronous electrical discharge from the neuron in the brain. Epilepsy, however, is when we have a chronic situation where the brain is predisposed to and has recurrent unprovoked seizures. And we know that in about a third of cases, these seizures will continue despite best treatment. And in these situations, we're calling it refractory or drug resistant. The International League Against Epilepsy suggesting that the definition of drug resistant epilepsy now should be considered as a failure of adequate trials of 2 tolerated, properly chosen anti-epileptic drugs, AEDs, either together or separately to achieve seizure freedom. There's no doubt that refractory seizures have devastating consequences for children and their carers. There's a direct impact of the seizures on development, academic performance and social development. There's an impact on the family. There's a much higher rate of comorbid psychiatric conditions, anxiety and depression in particular. And there's a huge impact on the siblings seeing their brother or sister having uncontrolled epilepsy. Indeed, there is also an impact of AED therapy. They have side effects, in particular when used in combination. So when we talk about refractory seizures, the consideration is what would be the best step? The first thing that's important to say is that you need to consider, are there other options beyond continuing medication trial after medication trial? And remember, epilepsy surgery. Epilepsy surgery provides the best chance of seizure freedom in those with refractory epilepsy and is not a last-ditch step. It's important to remember that the diagnosis of epilepsy is often difficult. Between 10 to 40% of those investigated for a possible diagnosis of epilepsy had non-epileptic events. So what are the predictors for who's going to be refractory or who's going to be drug resistant? Whenever we diagnose epilepsy, we're always trying to think ahead for this. The first, I suppose, is patient factors. Is there something different about this child in the sense of, is there an underlying concern about their development when they present? Are they presenting with seizures in the first year of life? And is there some sort of a structural malformation or concern on their imaging of their brain? Then there's epilepsy factors. There's certain syndromes that are just well known to be associated with seizures that are harder to treat. Multiple seizure types, having status, being admitted to hospital, and indeed failing to respond to the first anti-epileptic drug that's trialled. So what should we do if someone is refractory or drug resistant? Well, certainly they need specialist input. A history and physical exam, determining that they definitely have epilepsy and it's definitely drug resistant, and then doing the best tests you have available. So video EEG monitoring, hopefully obtaining sleep, sometimes even obtaining episodes, an MRI, and then other functional assessments. So as I've said, if someone is a surgical candidate, they would proceed with that route. And if they're not, the other choices are the ketogenic diet, the VNS, or other drug therapy. When seizures are drug resistant, the aim is to minimize the impact on the seizures by reducing the seizure frequency and severity and improving quality of life. Sometimes the goalposts shift a little out over time, and we're not aiming for seizure freedom. We're aiming for a balance between avoiding any unwanted effects of medication, such as unnecessary sleepiness, while still tackling seizures that could potentially cause injury or harm. The ketogenic diet offers seizure reduction of more than 50% in almost half of patients. Some patients do achieve seizure freedom on the diet. The vagal nerve stimulator has similar seizure reduction rates. It can be slow in its effects, however. What else is there? Often touted as the natural choice, cannabinoids are medications derived from the cannabis plant. From our perspective in epilepsy, we're predominantly speaking about CBD or cannabidiol. Another major component of the cannabis plant is THC. This is psychoactive. This is the property or content of the cannabis plant that is used recreationally to provide a high. CBD or cannabidiol does not provide a high. There have been multiple medicinal properties of cannabinoids considered long back into history and indeed more recently, with anything from inflammatory to gastrointestinal to psychiatric to pain relief and lots of other properties. There's more than 500 chemically active compounds within the cannabis plant, and more than 80 of these are cannabinoids. And these would be the main ones, CBD and THC. They work through the endocannabinoid system, quite uniquely when you think about our anti-seizure medicines. CB1, CBD doesn't actually, CB1 and CB2 are the two endocannabinoid receptors, and THC binds directly to CB1, and you can see there's lots of it there within the brain. Cannabidiol or CBD doesn't bind directly but works through an intermediary to assert its impact. And I suppose this was one of the postulated reasons for why there may be benefit or merit in adding a bit of THC. But really the evidence hasn't moved much beyond the fact that it is potentially plausible. The anti-seizure effect is biologically plausible. So this is a very complicated looking picture of a nerve synapse, which is where the message passes across from one nerve end to another. And too much of that message passing through can lead to a seizure if enough nerves are activated. And CBD and THC artifacts have impacts at a number of different points here. As illustrated. So it's biologically plausible at a nerve cell level that it would have an anti-seizure effect. Subsequent to that, it's also clinically plausible at a pre-clinical stage in animal studies. These studies were actually done in the 70s, and they found that CBD was mostly an anticonvulsant, and THC was also mostly an anticonvulsant, but THC could potentiate or could lead to seizures. Unfortunately, typically after this you would move on to clinical trials, but the culture that prevailed in the late 70s and early 80s was kind of prohibition in the sense of the recreational aspect of cannabis, and so this research didn't continue. Just a scattering of clinical trial data. So when we fast forward to the last decade, when we were all watching a lot of media activity, the Cochrane Library, which is sort of our central information source for a lot of doctors, would have looked at all the published research that's out there, which there was very little, I suppose, of being the point, and felt there was no reliable conclusion to be drawn at that stage. However, at the same time, we were all being bombarded with media reports and anecdotal evidence of amazing stories. Dr. Sanjay Gupta from CNN highlighted the case of Charlotte Fiji, who was a little girl with Dravet syndrome with very severe epilepsy, who had a very dramatic response to CBD. So where are we now in terms of clinical evidence? There have been years of clinical trials performed. These have predominantly involved pure CBD, Epidiolex, produced by GW Pharma. This was licensed by the European Medicine Agency in 2019. They reviewed evidence from studies, clinical trials with over 700 patients, children and adults, with an overall 2/3 reduction in seizures described. Some seizure types being more responsive, such as drop seizures. And these were children and adults with Dravet syndrome and Lennox-Gastaut syndrome. Higher responses were seen in those who were also on clobazam. And so the European Medicines Agency has licensed Epidiolex for use in drug-resistant epilepsy due to Dravet syndrome and Lennox-Gastaut syndrome in patients who are also on clobazam. This is an AED, and there are obviously associated side effects, which are well established from multiple clinical trials. Impact on sleep, sleepiness and insomnia, impact on appetite, including significant loss of appetite in some, diarrhea, and interactions with other AEDs, in particular clobazam, whose affected potentiates, and valproic acid. So knowing that, and knowing that there is a licensed medication, I suppose we're stuck in this situation as clinicians to prescribe or not to prescribe. There are a significant number of my colleagues who feel there is not enough evidence. Okay, we have the particular condition of Dravet syndrome in Lennox-Gastaut, but lots of patients who we see with drug-resistant epilepsy might not fit into those boxes. And also, I suppose, the concern around product type. Then there are those of us who do prescribe and feel you can prescribe. I suppose the clearest example for the green light is that Epidiolex, in order to be licensed, has to meet a certain burden of evidence to obtain that licensing, and it has done that. So what's the current status in Ireland? Really, from my perspective, I guess there's potentially three routes for treating a patient with medical cannabis for epilepsy at the moment. The first and the simplest, but with a significant cost, is to write a prescription in your clinic for a CBD medication. The family can simply take this to the pharmacy and obtain this medication as you would with any other AED. Epidiolex is licensed in that way, and there are other generic CBD formulations that are coming on stream, pharmaceutical CBD formulations. So this is not a bottle of CBD that you get in a health food store. That is a food supplement grade. That is not a medication and should not be considered in this instance in the same way. This is a prescribed medication with a dose of milligrams, extrapolated into dose of mils in oil, and monitored by your supervising consultant. 2 is the ministerial license route. And here's where things start to get a bit muddied, I guess. So the ministerial license exists for people to access medications that contain illicit substances. So I would apply for a license for my patient to allow me to prescribe a medication that contains THC. Now in Ireland, they've been over 100, actually more licenses have been given to date in children and in adults with drug-resistant epilepsy, with Lennox-Gastaut or Dravet syndrome, who meet certain criteria and are felt by their supervising consultant to be eligible to trial it. The Department of Health agrees, and a license is granted the consultant to prescribe for them, initially for a 3-month trial period. The family, the consultant needs to have an established route for them to obtain this medication. And really, there's only one kind of medication that has been prescribed in this route, to my knowledge, and that's Bedrolite. So Bedrolite is a high CBD, low THC cannabis oil that's obtained from Amsterdam and brought currently by the Department of Health into Ireland and delivered to the family. The first license permits a 3-month trial of this medication. And if it's felt to be effective families wish to continue, there's a subsequent route where they can apply for a reimbursement, but the charge up front is paid for by the family. None of these routes are covered by any funding, and Epidiolex is very, very expensive. The third program is the Medical Cannabis Access Program, which on paper sounds great and has a lovely web page. At the moment, to the best of my knowledge, this isn't up and running while it is reportedly funded. There was recent media reports on that. The idea behind this would be a wider program for lots of different conditions, not just for epilepsy. And looking at the product lists, there's 4 different products on it at the moment. At the moment, there are about 4 products on the listed on the Cannabis Access Programme, and 2 of these would be appropriate for use in epilepsy. So we hope that this will be expanded and that it will include more. So finally, I suppose currently the biggest barrier to prescribing CBD for epilepsy, in my opinion, is the gap in funding and the huge cost. I believe it's a proven anti-epileptic drug for specific populations, and the rationale for not funding is unclear. Growing evidence is emerging as there's widened use in more clinical trials. Indeed, it's being established now as an anti-seizure medication in drug-resistant tuberous sclerosis and in infantile spasms and other populations. I guess the question around whether THC is needed or ultimately beneficial is not that clear as yet. Finally, this is a picture of Charlotte Fiji standing beside a lot of cannabis plants. Charlotte was the little girl who kind of led the movement around cannabis for epilepsy in the United States and then worldwide. Story of this little girl with devastating epilepsy due to Dravet syndrome, who had a remarkable response to a cannabis product which was later named Charlotte's Web after her. Her story and the subsequent stories that were shared over the years have really led this movement and pushed it forward in terms of figuring out what are the medicinal properties of cannabis and which children and adults with epilepsy will benefit from a trial of this, which product is best and which dose is best. And it always reminds me how important the stories we tell are. I have learned from many families over the years, there are different ways of doing things. I'm humbled and taught to think outside the box on a regular basis. And I would urge families to share your stories with your doctors and nurses and tell them what slightly different or out there things you do and try and things that you feel make a difference, and that pushes things forward, and we definitely learn from that. And I think because of Charlotte and that family's willingness to share their story publicly, huge progress was made because of the sharing of stories. Thanks for taking the time to listen. We're going to move on to some questions and answers now. Yeah, so puberty are the constellation of changes that your body goes through when changing from a child into an adult, predominantly driven by hormone, and it's a huge period of growth. There's no doubt that hormone changes and growth can affect seizures and seizure control, and especially in girls, and we refer to this as catamenial epilepsy. There can be a real monthly pattern to the seizures, and the seizures being worse at certain times when periods start. So there's 3 different patterns of epilepsy that happen that can occur. About 10% of girls and women that have epilepsy. One is the commonest, where seizures seem to get worse around the time of the period, so just before and during the first few days of the period. The second is where the seizures are worse just before ovulation, so kind of 2 weeks before that. And the third is where for the second half of each monthly cycle, the seizures can get a lot worse. We understand that this happens because of the estrogen surge that you get, and also the imbalance between progesterone and estrogen. So estrogen can kind of cause an activation of seizures or electrical epilepsy activity. And so it isn't just an absolute amount of estrogen, it's more the balance between the two. So within that then, and I know you were asking about kind of what options would there be for treatment, that sometimes can provide some options. So the first thing is, as we always say to families, I think we need to diary out the seizures and try and understand how they correlate. So the seizure diary side by side with the period and menstrual diary to understand, is this a pattern thing? Is there a catamenial epilepsy? And then from there, I suppose,
Is it the pattern that would benefit from, you know, a natural progesterone supplement? Is it the pattern where you get a few bad days of seizures each month around the time of the period? That pattern of seizure activity might be amenable to an extra medicine for a few days, 4, 5, 6 days. Clobazam, one of the benzodiazepine groups of medicines, is one that has been used regularly in that instance, that you would take it for just those few days where the seizures are predictably significant, to try and stop that from happening each month. Outside of that, if there's no clear pattern, but we see things go a bit awry at the start of periods or with growth spurts, it's important to make sure that you're being really vigilant with all of the things that can be more difficult as kids become teenagers, namely sleep, eating breakfast, taking their medicines on time, balancing out screen time and exercise, and all of those are the things that we know are very impactful on seizure control as well. So it can be a bit harder to kind of regulate your teenager than it might have been sometimes with a younger child, but those are all important things to keep an eye on as well. And then sometimes we have to change the doses of medications during growth spurts. Some of the medicines make that easy for us because we can do blood levels and we can check and see the dosing of the medicine within the bloodstream. I think there are always new drugs in development, and you know, sometimes they don't make it all the way to kind of the pharmacy shelf for us to prescribe them, and they're held up for lots of different reasons, often financial and others, and sometimes it can take many years before they're kind of readily available. I think Briviact is one that is certainly now available in Ireland by Veracetam. So lots of people might be familiar with Keppra or levetiracetam. Briviact would be kind of an analog of this, or kind of a cousin of Keppra, if you will. And one of the concerns that people have sometimes with Keppra is that there's a potential side effect of, you know, kind of mood change and behavior change that we can sometimes see, often in a child who may have some kind of underlying ADHD or other concerns. And while some people will use, you know, vitamin B6 to offset that, another option might be Briviact. So sort of a newer version of Keppra that we think is somewhat less likely to have that effect. And I suppose also has the benefit of Keppra in that it's metabolized through the kidneys and doesn't kind of hang around within the body or the liver and isn't stored anywhere and doesn't need any extra blood work to be performed. So that's one option. Ezylcarbazepine and Charisbamate are two other ones that are in development, but not kind of readily available. Interestingly, a lot of the medicines that are being developed at the moment are for partial epilepsy. So where seizures are just arriving from one part of the brain, where a child or an adult isn't a candidate for epilepsy surgery, but continuing to have seizures. And that's a route where a lot of people are considering new drug development. More generalized epilepsies are sort of being explored in a different way for therapeutics, whether there's a kind of a genetic answer that might be amenable to a different type of therapy in the future, or whether there might be an inflammation reason behind the epilepsy and whether that might be amenable to another route of treatment, steroids or anti-inflammatory treatment. So it's broader than just anti-seizure medicine. And so we're kind of thinking about epilepsies in a different way, I suppose. So when a child or a young adult hasn't responded to the first two drugs that have been tried appropriately at the right dose for their epilepsy, we always look to consider what the other options are. And as I mentioned earlier, they would fall into determining whether or not they're a candidate for epilepsy surgery. And if they're not, considering what other options are available. And the three options at that stage will be another drug, the ketogenic diet, or whether they're a candidate for vagal nerve stimulation device implantation. Okay. From my perspective, the ketogenic diet is something that I often consider. And I think sometimes we can be a bit slow in getting kids on the diet when we see that it can have a significant effect on their epilepsy. Predominantly, we consider it for kids often who have a mixed seizure type, having lots of seizures, where despite a good number of medicines, they're continuing to have seizures, and often generalized epilepsies or genetic epilepsies again, where there isn't really a clear kind of structural reason or something that might be amenable to a surgery. The ketogenic diet works on the principle of ketosis, which is changing the nutrition for your brain. Instead of sugar or glucose, it's giving the brain fats. Those fats are then turned into ketone bodies in your liver, and that is used to supply the ready source of energy for your brain. In switching over from sugar to fat, we change the electrical connections within the brain, and somehow that process has a direct impact on the frequency of seizures. Again, like everything we try, we talk about levels of success, and we talk about, you know, this idea of if you get a 50% reduction in your seizures on the ketogenic diet, that's good. And, you know, sometimes we can see very dramatic improvements on the ketogenic diet. Certain genetic epilepsies will be very amenable to trying dietary therapy, and sometimes it's easy for a family and for a child to do, but there's no doubt that it's a huge commitment. It requires a very close relationship with a dietitian and your consultant and your team at the hospital. You need to understand exactly the process of preparing all the food, weighing it all out, ensuring it's all eaten, and then managing and monitoring the sugars and the ketones, making sure there's no incidence or any changes in body sugars as the body gets used to this new source of energy. Most people would have to commit to a trial period of about 6 months to try and, you know, kind of get to grips and see if it's definitely having an effect on seizures. Mm-hmm. And I think there are certain conditions where, you know, it's important to try and consider it early on. Often it's easier to give the ketogenic diet to a younger child. They're not kind of selecting their own food, and it can be easier to tolerate. A particular group would be young kids with infantile spasms. So in that infancy age group, there's really good data now for being quite proactive in starting the ketogenic diet early on. So if an infant has infantile spasms that don't respond to vigabatrin, that don't respond to steroids, they should really be considered. The ketogenic diet is an option. Other drugs that are options should all be considered at that stage. Often in an older child or a teenager, if we want to try dietary therapies for epilepsy, this sort of definition of dietary therapies has been expanded. There's lots of centres in the States that would offer modified Atkins diets, low GI diets, and manage them in that same strict way, accompanied by an expert dietitian, to ensure that it's an appropriate kind of controlled trial of a diet. I suppose the access to different types of diets beyond classic ketogenic, these maybe more palatable diets for older kids, would really depend on what is available in terms of expert dietitian support. And that's probably one of the biggest things in terms of, you know, access to the diet, access to an expert who can guide you as it's being trialed. It isn't something that you can kind of just do a bit of at home. It just doesn't work that way. Yeah, so I suppose cannabis as a therapy for epilepsy is something that's gained a lot of attention over the last 7 or 8 years now, and indeed is being acknowledged and used worldwide for drug-resistant epilepsies. There's quite a particular population of kids and adults that are treated with this. So when we think about cannabis, it's a very complicated plant. It's got over 600 chemicals that are active within it. And there's 3 different types of strains within that. And I suppose it's hard for us sometimes to understand exactly what we're talking about as a medicine. So particularly in epilepsy, we're talking about cannabidiol or CBD as the main active ingredient, as the active ingredient that has anti-seizure properties. This is not psychoactive, so it doesn't have any properties that would make a child or an adult who takes it high, as opposed to the other main component that is talked about, which is THC. And THC is the component that would be considered in recreational drugs. It does have the propensity to cause a high or a psychoactive component to it. And it isn't the predominant drug that's considered in epilepsy. So for the purposes of, you know, the clinical trials that have been done and the medicines that we're considering, most people will equate the anti-seizure medicine for cannabis as CBD or cannabidiol. Okay. And I think when should we think about CBD, I think was one of the questions I see there. We think about it for drug-resistant epilepsy. So that's where a child or an adult has not had a cessation of their seizures or a good seizure response to the first two medicines they've tried at an appropriate dose for an appropriate duration of time and the right medicine for their epilepsy. Because we know beyond that, your chance of becoming seizure-free really dwindles. And for a long time, despite new medicines coming to the fore, we don't feel that we've really been able to tackle that drug-resistant epilepsy group with what we've got. We're always looking for new medicines and new drugs. And so when CBD came along, everybody wanted to kind of, you know, jump on it, because I think there was a public perception that this was somehow kind of a lesser drug or a safer option, or sort of something people were more familiar with. In fact, it is a drug, and it has come through clinical trials, as every new drug should. And it has been proven to be effective for drug-resistant epilepsy in particular circumstances. That would be the genetic epilepsy. So Dravet syndrome was a group of genetic epilepsies that children and adults have quite significant seizures, often starting very early in life, that tend to be very difficult to treat. And this is a proven effective option for treating seizures in Dravet syndrome. The other group, which is a bit of a kind of a wider group, is called Lennox-Gastaut, which is a kind of a child or an adult who has a lot of different types of seizures and has an EEG that has a certain pattern, and is considered to be of genetic origin as well. So something within the child's DNA that kind of drives the epilepsy. And so we have evidence, good data, using a drug called Epidiolex. And most of those studies started in the United States, and then it was expanded out. The difficulty, I suppose, in Ireland with when to consider it or how would you access it and all of that is predominantly around, I suppose, clinicians' exposure to the medication, and then funding really is the big issue. So when you think of how you might consider accessing a medication in Ireland, cannabis medication, you must have drug-resistant epilepsy because it's not a first-line medicine. The first-line medicines are medicines that we've known about for decades, and at least 2/3 of the time usually work quite well, okay, to kind of stop the seizures and, you know, not cause any unwanted effects. And we have longitudinal data on them. So if you have drug-resistant epilepsy, then you try and decide, well, what's the reason for this drug-resistant epilepsy? Could this patient be a candidate for epilepsy surgery? Do they have focal seizures? If you do, that would definitely be a preferred route. If they don't, could they be a candidate for the ketogenic diet, vagal nerve stimulator implantation, or another drug? And in the context of another drug, you're trying to decide who would be best suited for a CBD medicine. At the moment, it's looking like the genetic group of epilepsies are the kids and adults who are most suited to CBD, who are most likely to have benefit from it. That doesn't preclude it from being tried in other epilepsies where you've kind of exhausted a lot of the newer drugs that have been produced are more for partial epilepsy. So they sort of have a route, Bivarastam, all of those other drugs that have been produced kind of for partial epilepsies. So if the decision is made that, you know, a child who either has Dravet syndrome, Lennox-Gastaut, or now indeed tuberous sclerosis, has drug-resistant epilepsy and is a suitable candidate for CBD, the challenge remains in Ireland how to access this in a cost-effective way. So Epidiolex was studied and funded and approved by the FDA in America and by the European Licensing Agency. Your specialist can write a prescription for Epidiolex and that can be prescribed. The challenge is it isn't currently funded or reimbursed through any scheme, and it's very expensive. In the spectrum of, it's about, 1,200 euros for a bottle of medication that might, last you a month or something like that, depending on the weight of your child. So for a lot of families, the cost is entirely prohibitive. There are other options of CBD only products. You have to be very careful about this, however. So to my knowledge, I'm only aware of one pure CBD that's produced in a pharmaceutical way by a specialist company in the UK and comes to Ireland. However, I meet a lot of families who are trying to access lots of different CBD products out there. There is no over-the-counter product that I would stand over as being suitable for treating epilepsy. They simply do not have the level of purity that we need. They're legislated and they're controlled in a different way. They're considered food supplements. That means that they have a very low amount of the actual active CBD drug within them. It also means they're not regulated in the same way. We don't have a good understanding of exactly how many milligrams is in every mil of a food supplement grade medicine or supplement. We don't see the same quality control. So a food supplement would have a very different structure in terms of exactly how much is in each bottle every time every batch is produced versus a CBD medication, pharmaceutical grade. They would have to stand over exactly what the content is of every mil in every bottle in every batch that's produced. From my perspective, I always want families to share with me and share, with whoever their neurologist or their doctors are treating them, exactly what they're taking. Whether that's, any kind of a food supplement or anything at all, I always want to know what it is. There's no doubt that there can be active compounds within these products, so it's very important to share that information. I think it's probably a bit of a stretch to think that they have large medicinal properties, though. There's also the possibility that there might be safety concerns. We're also cautious about exactly what medicine we give and the dose of it and how we sort of portion it out and prescribe it and how we administer it in our homes to our kids. But this is a little bit different when you can't be exactly sure what's in each bottle in terms of, often it might say an estimated content or a percentage. It doesn't mean a lot in terms of trying to understand an absolute amount of medicine. Beyond that, I suppose, what are the routes in Ireland? We do have a ministerial license route. So that was created on the foot of a clear need for families predominantly with Dravet syndrome and Lennox-Gastaut. Because of COVID, that medication is now being brought in by the Department of Health. So families no longer have to take this crazy trip that they had been taking to actually go to the pharmacy in Amsterdam, pick up the medication with their license and bring it back into Ireland. So thankfully that doesn't happen anymore, and that isn't going to happen again. And the government will collect that. So to meet criteria for a ministerial license, the child or young adult has to have drug-resistant epilepsy due to Lennox-Gastaut or Dravet syndrome, has to have tried, a reasonable number of medications, and has to have a clinician who feels that it's really worth them trying it. Families have to really fully understand that the potential pros and cons of trying these medicines and talk about it in some detail before that route is proceeded and applied for. And it's quite a process really, but it does exist. And it is there, and there are a good number of children and adults who do receive medicine that way. That license is specifically for accessing a cannabis medicine that contains THC. Okay, I cannot write a prescription for a cannabis medicine that contains THC. I can write a prescription for cannabidiol with nothing else in it, but not for any prescription medication that contains a THC. And so that is the route, and that is why the route exists for the ministerial license. to access what people would term, you know, like a fuller cannabis product, a cannabis product that contains THC in it. From a scientific standpoint, we don't have a high level of evidence that a cannabis product for epilepsy needs to have THC in it. Hasn't actually been studied. So while the early stories that we heard about a child in America who had Dravet syndrome that was, you know, kind of in all the media reports, she tried a product that had CBD and THC in it. All of the clinical trials subsequently through the United States were with a CBD only product. So it's a kind of, it's sort of come around a different way where they sort of picked out what they considered to be the safest part and the most likely from animal studies to have the biggest anti-seizure effect, which was the cannabidiol or the CBD. And that's been the product that's been sort of studied in a meaningful way. It has a good safety profile, and that is something that is, you know, can be quite appealing, I suppose, to families, but it does still have a risk of adverse events. The type of things that I see with CBD will be, it can have an effect on your gut motility, so it can cause diarrhea. It can have an effect on appetite, namely that actually kids lose their appetite and can be a little bit reluctant to eat. So not what people think when they think of their recreational products, but actually more that they lose their appetite. It can affect sleep, both in causing kids to be a little bit sleepy, which is not that atypical for something that we see with a lot of the anti-seizure medicines, but interestingly can have the converse effect and can cause some kids to have insomnia, which can be quite troublesome. And, you know, those are things that you need to monitor. So same as every other anti-seizure medicine, you start at a low dose, you would increase it gradually, you would keep an eye on interactions with other medicines, keep an eye on blood work. And so, as you can imagine, all of that needs the oversight from your consultant or your specialist or whoever is kind of taking care of your child or yourself and your epilepsy. And I suppose it's important to kind of have a very clear pathway for how long are we going to try this for? When are we going to say if it's been effective or not? Because it's expensive. And because even with the ministerial license route, the first license you get is for 3 months. And you get a supply for 3 months, which families have to pay for upfront. And the cost of that is not reimbursed. The only reimbursement happens if the medicine is felt to be effective. So they're not reimbursed for a trial of medicine. The third route then for accessing cannabis in Ireland is the Medicinal Cannabis Access Programme. I think we've probably heard a lot about that in the media recently, because it finally has been funded or, you know, has kind of made some further steps forward. To my knowledge, that isn't yet active. I think that's a little bit wider than just epilepsy. So that's thinking of a cannabis access program for lots of different conditions. When we think of pain and nausea and multiple sclerosis and lots of other conditions. And so that needs to be quite a comprehensive list of drugs, and lots of them will be, you know, wholly inappropriate to consider specifically for epilepsy. So at the moment, or certainly at last look, when I looked on the website, there was 4 medicines listed as part of the kind of cannabis access program. I'm not aware that any of them are currently prescribable or available or reimbursed, but that would be the hope, that that list would expand and include more medicines. I would say only 1 or 2 of those would be relevant for treating epilepsy. So we would like to see something more comprehensive to allow us, I suppose, to widen the options for people. People ask about what are the risks of the cannabis medicines. So one of the things that we talked about a lot and is concerned cognitive issues. So if we think of recreational, and again, it's often blurred when people start thinking about cannabis, there's a huge consideration about the cognitive impact of that and the impact on growing and developing brain cells. I think, you know, we don't have any data that says that CBD, cannabidiol, causes any cognitive decline. In fact, there's a growing body of research of using CBD, so pure CBD, in cognitive decline, and using it as an adjunctive therapy for that, because it actually can improve cognitive function. But I'm separating that completely from the wider kind of cannabis term and more mixed products and THC and recreational products. That's not what I'm talking about. They're not what I'm considering as medicine for epilepsy.